So, hi, I'm Rachel, and I'm meeting here with Dr. Blaskovich today. Dr. Blaskovich is actually someone I know from my own journey and finding my diagnosis and care after 14 years. He was the physician who helped put the pieces together. And he's also got a very strong goal and heart for advocacy. So, today, what we want to talk about is to help get the knowledge out there of the unique needs for assessment and imaging in regards to CCI and related conditions. There's a lot of nuances and there's a lot of people who are getting a lot of different types of assessment done and falling through the cracks. And I've been getting a lot of questions from people to try to get more understanding of why something's maybe not showing in imaging, but there still might be more, clues and cues. So, Dr. Blaskovich, do you want to introduce yourself?
Sure. Yeah, my name is Dr. Sasha Blaskovich. I am by design or by designation or education a chiropractic physician. I've sustained a particular injury 30 years ago playing football that was not properly diagnosed. And it took me the first part of my career to get to the bottom of what it was that I had that was not specifically a concussion, which is what the diagnosis was. And so that led me to study from all different tangents of what's out there, possibly. So, physiology, anatomy, neurology, radiology, piecing all that together basically to get to where we are right now. And it's a complex web of things that lead to one underlying cause generally, and that is the permanent damage of very important ligaments that hold the upper part of the neck together. And when those ligaments are damaged, the excessive movement that the upper neck then has as a lifelong sentence ends up causing irritation of the brainstem primarily and altering different fluid dynamic situations in and around the brain and the upper neck and the rest of the body, affecting certain important nerves, such as the vagus nerve that links to pretty much every background bodily function that we have, and thereby causing a massive gamut of different symptoms and dysfunctions and impairments that go underdiagnosed or misdiagnosed as something else when the central core of the problem is right there at the level of the brainstem. And it all ties into damaged ligaments, and whether they're damaged by trauma, whether they're damaged by some kind of a body-wide inflammatory condition or a connective tissue disorder that is either acquired or inherited. At the end of the day, the damage to those ligaments is the key feature that is similar to every case where there is instability causing all these problems. And so um, I've dedicated my career to basically learning as much as I can about this from all the different tangents and putting it into practice and advocating for people like myself who were misdiagnosed and continue to be misdiagnosed by physicians all around the world,
Yeah.
as this information is not globally and standardly known or even practiced,
Mhm.
thereby creating a large void in the capacity for answers to be obtained that are going to be effective for each individual who's living with a version of this problem.
Yeah, and patients are often seeing like a wide range of specialists because it's can be GI, neurology, heart problems. It really runs the gamut. And because this condition for a lot of us can progress over time, I think that there's a disconnect that, whether it's an infection or a traumatic injury, that these things can actually pair together so that that person doesn't necessarily have, problems with five systems in their body. There's a root reason that that's happening. And actually, I just want to also say that like you've built a reputation, which is actually how I learned about you. And I was actually getting very near the end of my road neurologically, but because other people knew of your work and how much it's actually helped, that actually was the reason that people had been referring to you. And I just think that you've got a very strong science-based reputation. And I think that's really important for people to know. This isn't just something we're thinking is happening. There's a lot of data behind this work. There just needs to be more awareness around that. So we're going to talk about imaging and diagnosis, especially because, as I've said, like people are ending up at different specialties and dealing with more of those like syndromes and symptoms, and they're not kind of getting to what could be a root cause and also what can give people more agency. So, whatever stage people are at with this condition, at least when you know you have it, you're better able to take care of it. There's a lot of things that can actually be kind of counterindicative of, when you have this issue, like working with the neck needs to be addressed differently. Different medications could actually be compounding the problems. Like I know for me, like, neurology was putting me on a heart medication. Well, that was very high risk for me because I was already having difficulties with like passing out and lightheadedness. So for people who are having symptoms that could be related to undiagnosed CCI and AAI, what specialists, clinical exam, and imaging have they typically received prior to seeing you?
They've usually been to neurologists,
Mhm.
physiatrists, their family doctors. Potentially, they'll get into endocrinology,
Yeah,
so someone who did rheumatology,
yeah.
and generally the gold standard or the go-to eventually would be a brain scan because they appear to have symptoms that would be expected to arise from within the brain,
Mhm.
whether it's memory loss, speech, word finding, blurry vision, tinnitus, ringing in their ears. So the assumption is that is brain related, and then
Mhm.
it'll either be an MRI or a CT scan of the brain, sometimes with or without contrast, only to render unremarkable or normal results because what they're looking for are obvious brain bleeds, aneurysms,
Mhm.
areas of focal necrotic or dead brain tissue. And at the end of the day, it occurs occasionally, but it's a very rare situation that is the true cause that is then found on imaging. And so then you get into the gamut of what you just described is certain organs are being affected or certain systems are being affected, and those systems then get addressed as an isolated petri dish.
Mhm.
And the possible logical overlap into other systems is not addressed because a cardiologist's training is to assess the heart and only the heart, and so they
Mhm.
focus on the heart, and it's not their fault. It's by design how they do their job and how they're trained to do their job. Just like a
Mhm.
rheumatologist will look for inflammatory conditions, and if there's no inflammatory conditions that show up in the blood work, then it's not an inflammatory condition. So their job is completed, and there's nothing much more that they can do.
Yeah.
I
And at
found
the
I
same time, you can have chronic inflammation, especially over time, that can be, wreaking havoc on your body. But
yeah,
because it's not that one specific thing that's become, acute, it could be something that needs to be addressed for your well-being, but isn't necessarily going to get flagged.
correct.
Yeah. Yeah.
Correct. Those are
Um,
the major ones that usually get involved.
Yeah, yeah. And it's interesting too. Like I know even for myself, there was, we'll get into a little bit later, but there was clues in my imaging, like a few things going on, but it wasn't pieced together because they're looking for that like really acute event to kind of make sense of it. So when you're considering instability, um, when you're looking at someone's symptoms, how important is their medical history? Like, so when you're trying to assess someone, you know, given what they've been through medically prior, is that helpful to you to kind of place together what might potentially be going on?
It is very helpful because the failure of efficacy of all the stuff that was tried, and then in conjunction with the gamut of symptoms that would be deemed cervical medullary, or what people get labeled with POTS, dysautonomia, ME,
Yeah,
CFS, as just to name a few. I mean, all those diagnoses are accepted diagnoses, but if you break down the actual term, it just explains and describes symptoms.
yeah,
It's not a causal diagnosis.
yeah.
Well, and so determining the ligament damage is then what would become an actual factual mechanical diagnosis
Hmm.
that would then allow you to render the logic behind how that can affect the neural system or the neurological system, rendering the symptoms that then get labeled as POTS or get labeled as dysautonomia.
Hmm.
So you got to work backwards to the cause to be able to explain the label that people have been given that doesn't really explain the origin.
Yeah, totally. And also too, like sometimes there's also different variables. Like I know for me, earlier on when I was having more heart issues, it didn't always correspond with exercise. And so I kept trying to, work with my system in that way. But I couldn't make sense of it. And actually, after getting the diagnosis, I actually started to figure out that time upright, having my neck worked on, all sorts of things related to that pressure, that gravity, and whatnot was actually aggravating my symptoms. And I also realized that because my eye involvement is so like interconnected with what was going on in my neck, the more I had to use my eye for tracking and the more I was sitting up with that, I actually had way more symptoms. But who would place those things together? And so it seemed like this randomness, but actually over time, it still was intermittent and varied. I started to be able to make sense like, oh, like the sitting up is the problem, not necessarily the physical activity, although the physical activity can show me like, okay, my heart rate shouldn't be, 186. It gave me those kind of clues. Um, so if a patient suspects the condition could be related to instability, so cranial cervical instability, atlantoaxial instability, even some cervical instability, but they only have access to standard imaging, so MRI, CT, or cervical X-ray, what imaging would you most recommend and why?
I would probably recommend what would be deemed in the current system as a functional X-ray or a
Okay.
dynamic X-ray, which is not really dynamic, it's just positional. So they would take the regular front to back X-ray, a side X-ray,
Hmm.
a front to back with the mouth open.
Okay.
And then they would do a side view with the patient's head bent forward and the patient's head bent backwards.
Hmm.
And I think that's a routine that every radiology technician who does the actual imaging at whatever facility on patients
Hmm.
can easily do because they've been trained to do that.
Yeah.
There are additional still shots that they could do that would take them outside of their box and comfort zone that would require a little bit more um, explanation and examples of, which I have
Hmm.
done to patients from around the world where they've done the usual flexion and extension positional x-rays and the information rendered is not quite enough.
Hmm.
And so then I would basically formulate the verbiage for them to take to their doctor to then write on a requisition that they could then take to whatever x-ray facility was local to them in Sweden or wherever they are,
Hmm.
and have the radiology technician perform that. And I would give them a sample of what that looks like so that when the radiology technician does that
Yeah.
outside of the box picture or those outside of the box pictures, when they see what they see on their screen, if it doesn't match up with those samples that I sent the patient, then they just redo it.
Okay.
But I would say that would be the next closest um, beneficial way to test out dynamically for instability, because
Okay.
every
The
other
important
imaging
thing is the flexion extension
positional,
one of the really important pieces?
it technically is, but that only tests for one particular ligament, and there's a whole
Okay.
gamut of other ligaments in the upper cervical spine that do not get they're not as important and relevant in flexion or extension. They're
Okay.
utilized for other movements like side to side bending and rotation,
Okay.
which you can't test for just in that flexion and extension position.
Okay.
That's one of the three possible planes of motion. So when you're calling that, either you're calling it dynamic, which it's not, it's positional, and you're then as a radiologist reporting on that region or that area as normal or abnormal, but you only have 1/3 of the possible positions that can be taken by that anatomy, then
Oh,
you're
interesting.
commenting on normal versus abnormal only on 33% of the possible information that you can obtain.
Okay.
And that's where you get into the benefit of the motion x-ray, the true motion x-ray real time, because that is assessing somebody's neck in all three planes of motion, so that you have a better understanding or idea of the potential different ligaments that could have been compromised by whatever the cause was that brought the person there in the first place, as opposed to just evaluating dynamically or positionally just in one plane of motion.
So that type of X-ray could kind of give some information on where vertebrae could be moving and potential neurological compression, but it can't rule out that there's other movement that could be happening that could also be causing a lot of like neurological symptoms as well.
Correct.
Great. Okay. And
It'd be
so
the
also,
equivalent. It would be the equivalent of looking at a used car that's been really nicely shined up at a used car dealership,
yeah,
and you can only look at it from the left side, and they assume that it must look good on the right side too,
yeah,
but not actually look at it from the right side. So you'd have to go to the right side and then the front and back too, technically, to be able to comment on the totality of that
gotcha.
vehicle's good looks. And so
Yes.
with this imaging, if you're just doing flexion and extension, that's only the x-axis of positioning or movement. You
Okay.
also have the y-axis, and you also have the z-axis or z-axis for the US people, right?
And can they do that with standard X-ray?
Yep.
Okay. So they would still be doing all of those, but it's still like if someone asked for it, could they get all of those movements, but it's still limited. There's still some ligaments that won't show or
The limitation is determining the severity of the ligament damage. So
okay.
I always had the presumption or the assumption that when you hit the end range of a particular movement, so let's say you go to maximum flexion and you take an X-ray,
Hmm.
that at that maximum flexion point, when I'm holding that position, the maximum amount of slippage or abnormal movement is going to be caught by the X-ray.
Hmm.
However, the way our neuromuscular system works, and this involved me looking at thousands of DMXs or motion X-rays to be able to
Yeah.
see this, and it's a finite thing that occurs. But when you get to the endpoint, say you do have instability, and you get to that endpoint, and there's a bone that slips,
Hmm.
and you hold that point, that bone will slightly recalibrate because of the neuromuscular desire to relocate things that have gone too far.
Hmm.
And so when you get to that endpoint and you get the patient to hold there, because it's slightly recalibrated, you're not getting the full magnitude of how much it slipped.
Okay.
Whereas when you look at the video in real time, you can actually pause it when you see the maximum end of slip or point of slip before it recalibrates.
Hmm.
And then that would be then where you take your measurement as opposed to just the endpoint that's been held on a static X-ray. And again, like I said, I would have assumed in a previous life that that would be the absolute maximum. And so whatever you yield in that endpoint that's held in a side view must be the maximum amount of aberrant motion, but it's not.
Yeah,
And
and
so
that's
that's
important too because like even though you're only hitting neurological structures for a short amount of time, that's also going to harm them more than that point where they're actually taking the imaging, correct?
yes, yes,
Yeah. And the other thing
yeah,
actually might be important to point out too is that like I know for myself when I would have imaging and I had to do positional things or even in clinic exams, my neurological symptoms were worse later. So it did compound for me. So you're at the time and they're examining you, but it's actually that snowball effect where that ball goes around and around, more snow's going around it, and the impacts kind of get more intense as time
cumulative.
goes on.
Yeah.
Yeah.
And
Um,
so basically tying back into your question there, the benefit of having the real time and being able to truly measure the full magnitude
mhm.
of that motion is that especially when somebody's dealing with somebody else being at fault for that injury potentially,
Yeah.
there are criteria that would determine the magnitude of the measurement would determine the severity of the injury,
Mhm.
and whether or not that injury measurement falls into a criteria that is compensable. And so when somebody's sustained a irreversible, permanent, lifelong injury that's going to cause recurrent symptoms for the rest of their life, the knowing that information is relevant for their process.
Yeah.
And so um, static imaging doesn't fully obtain the magnitude of the injury. It'll show
Yeah.
you an indication of that,
Okay.
but not the magnitude.
Yeah. And then as far as like so if somebody doesn't have access, like that's a good starting point where we can be information gathering, right? And maybe if
Yep.
there's some information there, there may be some non-invasive therapeutic measures to start trying it. For example, it kind of gives people like a starting point. At least for me, like I was never offered any type of X-ray in different positions. I did MRI, CT, contrast, not contrast, and whatnot. So as far as like MRI and CT, how does that work as far as like what they're trying to see, especially when positionally you're in supine. So supine means you're lying on your back, there's no gravity, you're not moving, and then they're doing their imaging there. Like some patients, as their neurological symptoms are getting quite severe, they're getting those imaging, they're maybe getting some little bits of information from it, but like um is it still useful for someone to do that type of imaging?
Absolutely. Yes, it
Okay.
is. So generally, when people come to us, they've had multiple different types of imaging done, so CT scans, MRIs. And I'd probably say more than 75% of the time, there are very subtle signs and findings on those CT scans or MRIs that um, provide a suspicion for ligament damage. For
Okay.
example, one of the more common ones that we see is that when they do this sort of what's called an axial slicing, so you're actually looking into the actual spinal canal. At the
Mhm.
top of the neck, you've got the ring that belongs to C2, C1, and then there's a peg from C2 that's supposed to be dead center in that ring.
Mhm.
So if I don't know how to do this properly, but let's say this is supposed to be dead center, but however, we see it way over to one side. Just picture this, where you can see that light going through on one side, but not on the other side, whereas you're supposed to see light on both sides like this.
Mhm.
And so when it's pasted off to one side, that is a very common indicator that one of those diagonal ligaments or potentially both to some extent, has been compromised or stretched or damaged or torn, because that peg should sit dead center of that ring and not off to one side.
Okay.
And so that is and that gets missed all the time. That never gets reported on. So when we get the imaging and look at it prior to doing the motion x-ray and even, assessing the patient for the first time, that is a very strong indicator that, if they have dizziness, nausea, vertigo, all those symptoms, that there's a logical explanation for that. And when we test them out in motion x-ray, we inevitably find that they do have instability there every single time.
So do you think that people are getting categorized as normal when their DENS is over, where they're actually in the wrong cohort because we keep calling people normal who have their DENS over? Is it more likely that that's seen as, nothing suspicious at all? Or do some people with a DENS that's over not have symptoms?
Well, I mean, we obviously get just symptomatic patients. And so
Okay.
um, we have both. We have patients that have symptoms that are dead center, and then we have patients that are symptomatic that they're off to the side. But when they're off to the side, they always have symptoms from what I've observed thus far
Yeah,
clinically. And so that is
including
to me,
me.
yeah. So that
Yeah.
is a very common thing that I find with people who have symptoms,
Hmm.
um, and therefore they come to us and we find that, and then that is, the first tip off that there's likely something going on.
Gotcha.
Is if you were to be able to, access all the CT scans that, are being done in hospitals and just pull out that slice from there and get the background on those patients that are potentially asymptomatic, but generally they're not getting that imaging done if they're asymptomatic. And so I don't know the answer to that if you were to globally look at that, but from the patients that we've seen that have that, they all
Mhm.
have instability.
And I guess what it's also saying is that it's a trend worth paying attention to because if some people who you don't see that, clue or red flag on, still when in movement, their neurological structures are getting impacted and they're having symptoms, then for people who it's stuck over to the side all the time, like that kind of should be at the very least paid attention to and at the very least studied because it's a useful
It's relevant.
finding.
It's definitely
Yeah.
relevant. And I do know that I do occasionally see a radiologist write in their report that it is not center,
Hmm.
and they will potentially write in a comment on there, potentially due to positioning, poor patient positioning, or they might note considered a normal variant. So
So should your
uh,
DENS move, like, should that
not
move
not
over if
when
you're
you're not
positioned?
where, like you just explained, that the person's supine or recumbent in the neutral
Yeah,
anatomic position. So when you're in a neutral anatomic position and you haven't been, poorly positioned or stressed or somehow forced into a non anatomic position, it should be all center. It should all
yeah.
be balanced out. So
And does
um,
your DENS move around when you're like if someone's got perfect ligaments, should their DENS be moving around like that in general? No.
no,
So
and
it
and
always
that's
meets something.
correct. And that's why that criteria for when they do the flexion and extension x-ray, like you're talking about something that has a, 1.5, 2 millimeter gap. And if that gap goes beyond 3 millimeters, so an additional millimeter,
Hmm.
millimeter and a half. So let's say it becomes 3.5 millimeters that they measure. That's considered pathologic damage to the transverse ligament.
Hmm.
So
Okay.
there's only a uber finite amount of, let's say, movement that's allowed there that shouldn't be able to be picked up on imaging, especially in neutral, without the person being stressed.
Yeah, and
So
I
when
guess
they're
it's
in
also
neutral,
yeah, it's also paying attention to people's symptoms because like I've seen and heard things where people are like, well, some people have instability and they don't have symptoms. But as you've spoken to before, your anatomy plays into that. Like you've talked about, the size of your spinal canal versus how much room is there for your brainstem and whatnot. But it's great for people who aren't having symptoms. I don't know if they'll be like that for the rest of their lives or not, but also for people who are very symptomatic, you know, it's worth paying attention to these things because comparing it to somebody who's not having challenges and overlooking that information, especially when we do have a lot of patients who've had care and had a lot of improvements in function and life and whatnot. And then the other piece is that, like, I mean, my situation took me to neurosurgery and neurologically really downhill. Like I've done very well post surgery, but I'm also still living with, like a lot of symptoms that are still challenging today. But I think for people to get this information and be able to support their system sooner, they're also preventing that like repetitive damage to their neurological structures when possible. And that's so important to, give that agency.
it
Uh,
is. And even if a person doesn't go for surgery, the knowledge of what's going on in there should allow there to be a, predication of which types of passive or um, conservative types of treatment should be contraindications
Yeah.
and which ones should be implemented, because generally the patients present as stiff and rigid. And
Hmm.
so the presumption is made that things are stuck and they need to be loosened.
Yeah.
And at the end of the day, the core problem here is that things are too loose, and the body's attempt to compensate for that creates neuromuscular rigidity, which then you present with rigidity, stiffness, reduced range of motion when you go to some kind of a therapist or clinician,
Hmm.
and they then assume that their job should be to focus on restoring that range of motion, improving joint mobility, when at the end of the day, the core underlying problem is too much joint mobility. And that's why the body's reacting this way, to try to
Hmm.
protect both the joints plus the neurology that's going through there. And
Yeah.
so when then the focus becomes improving range of motion, stretching, tractioning, adjusting, you end up actually recurrently irritating that neural tissue, which, like you said, causes the recurrent flare ups, which over time are not beneficial. And so reverting back from that and addressing the situation once you know this information diagnostically to change up how you address the treatment of this could make a world of difference. It might not, bring you back to the perfect specimen of health that you were or want to be, but
Hmm.
at least the repeated flare-ups from, therapists trying to do you good, but in the end, not doing you good because the approaches for the wrong pathology
Hmm.
can be mitigated, whereby you finally start getting therapies and treatments that are geared at treating the tissues that are responding to instability as opposed to creating more instability, or at least um, irritating the instability, if that makes sense.
Yeah, it makes perfect sense. And I know for myself, like I didn't, there was things I absolutely didn't do, but there was a lot of things I just kept trying because the understanding was that that was really important, like range of motion, blood flow and whatnot. And also sometimes too, like you can get a treatment where you actually feel, well, I would feel a little lightheaded, but I'd feel more blood going to my brain. And I was like, phew, this is good. And I wouldn't be able to kind of correlate that, like, I started to feel worse later that day, and then it would compound and whatnot. And I think that if you don't have the knowledge about these conditions and what they need, it's so easy to overlook, the symptoms and what's compounding the symptoms, because as far as I knew, that didn't exist. It had to be a me problem and how I was perceiving it. I must be doing something else wrong versus, great practitioners, but it wasn't the right thing for me, particularly in the region of my neck.
Yeah.
Um, so when we're looking at like red flags and clues, are there other types of clues that get seen? Like, are you seeing things getting missed when you're imaging in supine, like things related to vascular compression, functional stenosis, Chiari? Like, how does
Uh,
that play in with supine imaging?
they are getting missed. This is my personal opinion about the upright versus recumbent, is that there are only a few samples, and this is, I've been tracking this for probably the last 8 to 10 years, that if you go onto Google and you just type in recumbent versus upright MRI, there's only a few samples of the massive difference between an upright and a recumbent Chiari that pop up. And that's not to say that there aren't a lot more out there that are being seen, but just not being uploaded onto Google and being found as images. But my personal experience that I've had with patients who have had recumbent MRIs and then go end up getting an upright MRI, as far as how far or how much of a difference their Chiari, or if they're going to call it that, generally it's not 5 millimeters, they don't even call it that, but their low lying cerebellar tonsils
Mhm.
go further low lying in the upright position. I personally clinically haven't seen that as dramatically as has been, propagated out there in the conversations. And so I don't think there's a massive limitation in just doing recumbent imaging, but then doing it stressed. So where you're trying to put ligaments to their end load or their
Mhm.
endpoint load, where you may see, fibers that are frayed and light spaces or fluid spaces around them, as opposed to doing it in neutral where the ligaments are all buckled and you might not get a true idea of their damage until you actually put them under a stretch load. That's my,
So the
would
position would be the stretch load. So like MRI
correct.
under, okay.
So an MRI done with a patient's head fully rotated, and then they do the slicing with their head maintained in rotation, because they
Uh,
do sometimes MRIs with patients with and CTs with flexion, and then they'll do the slicing and extension.
yeah.
But they have to get into doing rotation and side tilting while they're doing the MRI slicing, because it
Yeah.
is possible. I mean, I've seen, scans from patients from Germany, from um, Guatemala, and different South American countries where they're doing this not routinely, but quite often.
Mhm.
And it is fascinating how much cool stuff you can see on those positional MRIs. And we've been trying to, convince the local MRI facilities in BC to do just rotational positioning, and they're claiming that their machines don't have the ability to do that, but they do.
Yeah.
Unfortunately, I think the issue is that they don't have radiologists that are willing to sign off on the reports when they're doing non-routine MRIs, and so they need to start learning a little bit more about what they could possibly see with the rotation MRI and start educating themselves so they can actually feel comfortable reporting on these things,
Mhm.
because it will yield a lot more information for patients as we start getting more radiologists that are training themselves in this and comfortable reading these MRIs, because people can always go on to different platforms and get a second opinion from a neuroradiologist from Britain or somewhere else that has been trained in this and has been practicing this, so that even if the local guys are not willing to comment on it because they feel the liability is too high, they can at least say it was done, and the patient's going to go get a second opinion read from somebody who knows what they're looking for.
So is it like a liability thing because there's not a standard criteria? So like
Well,
you
there is.
flag
It's
normal.
there is. It's just not being practiced.
Oh, interesting. And is in
Because
that,
like,
does Canada have that?
what do you mean?
A standard criteria for if someone was able to do a MRI imaging in rotation, left, right,
Hmm.
would a radiologist be able to sign off and flag? Like, do they have that criteria to
Well, the
note?
criteria exists. Whether it's being recognized in Canada, I
Oh, I
don't think
see.
so, because it's not
Yeah,
being practiced. But there
gotcha.
is a criteria out there. There are, different venues where people can learn, as radiologists can learn about what to look for in different positions, because it is being reported on, it is being conducted around the world, just
Gotcha.
not yet collaboratively, globally. So it's at some point in time, it's going to have to be, because functional imaging for the musculoskeletal or musculoskeletal system, so skull, spine, and appendages, is
Mhm.
going to have to be more and more conducted in dynamic stress types of situations versus neutral anatomic, like you
Yeah.
mentioned earlier, because you miss a lot when you're just looking at neutral anatomic versus, stressing somebody. If somebody says, when I bend my knee this way, it hurts over here, ultimately the logical thing would be to have them recreate that under imaging sequence
Mm.
situations, and then see what you see at the place where they point to. And if you don't see anything, then it's likely a soft tissue. If you see something bony occurring that's weird, then you can sort of, deductive reasoning can help you figure out what it might be, so that somebody who's going to do something procedurally or therapeutically with it will have a better idea of what the specific problem is, so that they can address it without having to guess.
Yeah. And are there other like, so I hear from patients like around the world essentially who are like just desperate to find out like, is this something I should keep pursuing? They keep telling me nothing's wrong. So when we're talking about like red flags or clues, um, do you see like in your patient base like people who are having more like vascular inflammation and like those types of symptoms, so RCVS, vasculitis, like are those patients tending to also come in with those types of um, little bits of clues in their imaging as well?
Yes, yes, there's a
Okay.
lot of overlap. And so
Yeah.
people from around the world, they, like you said, they do get that, there's nothing wrong with you kind of thing, or we can't figure it out kind of thing.
Yeah.
And oftentimes there are clues. And so those are the types of patients that will then contact me and or my assistant, and they'll send us the imaging, and I'll have a look at it and look for these clues, and then relay that to them in an
Okay.
explanatory video, so a Zoom call like this, and then hopefully guide them along the path of being able to bring that information to somebody wherever they are locally, their doctor, like I said, Sweden or Guatemala or wherever they are, and have a discussion at least, and start that conversation going. Because like you said, everywhere, doesn't matter where you are, this is definitely falling on deaf ears,
Mhm.
to the physicians for most patients.
Yeah, and people are just thinking like, okay, it says I'm normal, therefore we don't continue to investigate, despite the fact that I'm having progressive symptoms that are,
Yeah,
getting more and more life limiting, but also kind of
yeah.
starting to become
So
risky,
they
I guess.
benefit drastically from having their hand held, for example, by someone like myself,
Yeah,
who can, knows both sides of the spectrum and knows what the doctors need to hear, and I can, formulate
yeah,
verbiage for what they would bring to their doctor, and help them through that, so that it's not basically falling on deaf ears,